Good afternoon. We are going to be talking to Dr. Kevin McChord today. Dr. McChord is a family practitioner and has a major focus on prevention. In fact, what he's going to do is share with us today his own story. As you may remember, I've shared my own story in terms of my profession, starting off as an ER doc and then going into prevention, teaching at Johns Hopkins, and then spending a career mostly teaching other docs to get more focused on discovering the metabolic drivers of disease and then getting involved in preventing the disease before the disease occurs. Dr. McChord is taking a similar route. I think he took a few more years in the standards of medicine before he got into prevention. But again, he'll be telling us about that today. Before we do, just some samples of some of the previous content we have, ranging from COVID-19 to major focuses on insulin resistance. You know, if there's one thing that we want to accomplish in this channel is help people understand and recognize the dangers of undiagnosed insulin resistance and the opportunity in managing insulin resistance, prediabetes, diabetes. We had another patient just yesterday whose fasting glucose. I mean, his fasting glucose was in the 80s. Soon as we challenged it, it went up to 238, and so he's clearly got full-blown diabetes. Didn't know it. Didn't even know he had insulin resistance. But here's the thing: on a regular basis, he rarely gets over 120. And that's because he's managing his carbs, he's managing his lifestyle. Michelle and Janice would want me to let you know we've got a Got Sugar webinar going on, some sort of special on it, by BOGO, I think, buy one, get one free. And we're doing that with our new partner, I'm Aware. You can now do this at home. You don't even have to go to the lab to get that done. So I have to share my continuing pain and the continuing saga on getting that book out. Actually, we're getting closer. I'll just leave it at that. We're getting more and more downloads of our podcasts. We've got over 31 episodes out there now. Now, let's get started with Dr. Kevin McChord. Dr. McChord, you want to go ahead and introduce yourself to us?
Hey, good morning, Dr. Brewer, and good morning to all the PrevMed tribe. Thank you for having me join the program today. It's been an honor to make your acquaintance and to collaborate on not only rehabilitating my own health, but working in this world of educating people on cardiovascular risk and prevention. Just about 2 years ago, in fact, last week marks the 2-year anniversary since I survived a heart attack. And that came as quite a surprise because at the time I did not exhibit any of the typical characteristics of someone you would expect to have an MI. My weight was appropriate. I had already made some positive changes in my life, recovering from some years of extraordinary stress. And the red flags that would have alerted us to the danger of an impending heart attack only appeared in hindsight. I suppose that's always the way, hindsight 2020. We're doing some Monday morning quarterbacking. But I had quite an experience, was hospitalized multiple times, underwent several cardiac procedures, underwent 2 rounds of cardiac rehab. And so now, in the 2 years since, that has changed my professional focus in the direction of my practice. And now to begin to deconstruct the story, that takes us back about 6 or 7 years earlier. For a completely unrelated reason, unrelated to my liver, I underwent a CT scan of the abdomen. And fatty liver was one of the incidental findings. Well, upon follow-up for the other issue, the fatty liver was brought up only because I brought it up with the physician who ordered the scan. And in our discussion, well, Kevin, this is a common condition. Lots of people have it. Watch your fat intake and try to reduce your weight. Take some vitamin E. But there was no other specific guidance provided to me. And I'm an MD, and I was talking to a colleague who I know and trust in his area of expertise. It was explained as though it's a common finding. We see it frequently. Just pay attention to it. If it gets worse, we'll make a referral. Well, I had to learn. I had to educate myself on this. But in the meantime, there were a number of other stresses in life. That's a broader story, dealing more with some of the roots of what influences our health and well-being. My own diet and nutrition, my own stress level, the presence of toxic and stressful relationships and employment situation, nutrient deficiencies, irregular sleep patterns. All of those things were present. And as I progressed through those years prior to a heart attack, I actually experienced an episode of a DVT. We never could figure out where that was coming from.
Let me interrupt with a couple of definitions. We'll get to DVT in a second, but a minute ago you said you had an MI.
Yes.
Stands for myocard. For those who don't know, that stands for myocardial infarction,
Yep.
and that stands for heart attack. Explain for the non-physicians in the group what we mean by DVT.
Oh, yeah. So I experienced a blood clot in my leg. Now, that was after you think of things that may provoke a blood clot in the leg. I hadn't done any long-distance travel. I hadn't undergone any major medical procedures. I hadn't been hospitalized.
You weren't a smoker, were you?
I'm a lifelong non-smoker. So at the time, my BMI was somewhere between 25 and 30, so I qualified as overweight. But on a day when I was out hiking, I had a hiking boot tied on, perhaps a little too snug around my calf. And after that, it lit up an episode of inflammation in my leg, and it eventually resulted in a blood clot. Now, it resolved. But again, this is another one of the clues as we look back. There was something really wrong. There was something driving massive inflammation in my system. Until finally that day when I experienced chest pain. And I had already undergone a stress test. I'd passed the stress test. It's not that it was a bad test, it was just the wrong test for my situation. So I'd already been through a battery of tests. I had finally turned the corner, was making changes, healthy lifestyle changes, was dropping weight. And according to the good old Framingham risk calculator, I got a pat on the back from my primary physician. And he said, Kevin, whatever you're doing must be working. Keep up the good work. The Framingham risk calculator says you've got less than a 3% risk over 10 years. 4 months later, I was lying in a hospital bed with a collection of stents, and I had just survived a widowmaker heart attack event.
So that sounds like you're not such a big fan of Framingham at this point.
I think there are better ways. We all know there are better ways of doing this. This audience in particular is well aware.
Could I just put that in perspective? I mentioned that book that we're working on and the headaches associated with it, but that book is about this issue.
Yes.
The typical thing when you go in to see your doc is he'll do a Framingham. That's a risk estimator based on mostly on information coming out of the Framingham research program in Framingham, Massachusetts, about an hour outside of Boston. There are problems with it. One of the biggest problems is that it doubles, for most people, it doubles your risk of having a heart attack inappropriately. And the question is, can you fix that? No, not really, because the previous ones are even worse. They're based on epidemiological studies. And as Kevin has just pointed out, you know, it can go the other way as well. And so then the next thing that happens is your doc will say, well, why don't we get a stress test? Stress tests, about a third to a quarter of them are false positive or false negative. False negative is a problem. That's what you had, a false negative Framingham.
Yeah.
False positives on stress tests end up taking most people into the cath lab. Once you get into the cath lab, most cardiologists will go ahead and get you to sign off on doing the stent before they even put you under. So that's that just evil triangle. The stress test, cath lab, and stent. And the reality is, what you need to know is your metabolic risk. You need to know whether you have plaque. It's a totally different story. So thanks for letting me put that plug in for a different orientation on medicine.
Exactly.
Go ahead, back with your story.
Well, after that event, as I recall lying in a hospital bed, I came across a series of videos from a Dr. Brewer in Lexington, who at that time was still holding pieces of paper up against the camera to illustrate the point of his teaching. And I thought to myself, I need to meet this man. So we connected a few months later, and it was only at that point that we finally unraveled the mystery of what had been occurring, and that was insulin resistance. So it was a core component that helped explain a lot of these smoking guns that we were finding in my medical history. And it was only when we began to tackle that issue head on and understand not only the metabolic markers that were out of range, but what do those markers mean? What do they indicate? Secondly, how hot is the fire inside? What can we learn about numbers that measure or assess vascular inflammation? And then the third component is, how do we appropriately assess the presence of plaque? What is the plaque burden in the body? Now, in my case, I already knew that I had it. But bear in mind that even my interventional cardiologist was very surprised that someone at my age and with my medical profile had such extensive coronary disease. So his job is to be an expert plumber. So he got me out of trouble when I needed it. So thankfully, there was a high-level intervention, and actually it required several of those procedures. But on the back end of it, other than prescribing high-dose atorvastatin, there wasn't much more. That in a daily aspirin wasn't much more to offer. So that was a completely different discipline and lifestyle change.
Kevin, did you have a stent as a treatment directly for your heart attack?
I did, yes. So that is what stopped the event. Then I continued to experience some unstable angina and had to go back in.
Just another point for orientation for folks. You hear me time and time again talk about how a stent won't prevent heart attacks.
Correct.
Stents are very much indicated and life-saving when they are given, when you're able to give a stent as a treatment for an active heart attack. The major issue is 90% of stents were not done for treatment of a heart attack. 90% of stents are done to prevent a heart attack, and they just don't work for that purpose.
Correct.
So you're bringing up some great teaching points, Kevin. Thank you.
You are welcome. Yeah, so my life and my career at this point pivoted into redeeming this whole experience for something far more beneficial. A huge number of people experience a first-time cardiac event without really any prior warning, or other issues have escaped. They've passed beneath the radar until ultimately someone is in deep trouble, or they don't survive, or they survive the event with permanent disability afterward. So being aware of that now, a lot of cases that I have seen through my career suddenly begin to make sense, where I had some gut level suspicion there were greater issues at stake, and merely throwing a statin or medications after a particular problem, all we were trying to do was adjust a particular lab number, not really understanding the importance of that lab number. What does that mean? What's going on inside someone? What kind of internal chaos is present? And how can we correct that chaos and quiet that fire? And that is ultimately what reduces someone's risk. We're not looking for, we're not really looking to take somebody's numbers necessarily and correct them to perfect levels, but we are looking for progress. We're looking for improvement. And I believe that is where significant risk reduction and improved quality of life occurs.
So, Kevin, you have you've added some new capacities, some new services to what you do. You want to tell us a little bit about that?
Yes. So my wife and I have we're a husband and wife team. She has also had in her career in medical management and administrative capacity. She's had her own health challenges, so that we have a partnership that we call Second Chance Health PLLC. there's our effort to redeem our own experiences for the benefit of others at large. Everybody deserves a second chance. We're thankful for our own second chances, and want to see that spill over to other people. So we're taking this combination, what we've known out of the world of conventional healthcare. We don't want to completely disparage pills and procedures where necessary. There's an appropriate place for them, but we want to do more than just merely perpetuate someone's diagnosis or their pathology. We want to get over to the other side of this thing. Where can we really leverage health? And that's getting into the root issues of how diet and nutrition, how exercise or sleep pathology, poor oral health, exposure to toxins, toxic relationships or environment, how nutritional deficiencies affect someone's health. Well, we don't have a way to prescribe that. Those things don't come in a pill bottle, and there certainly isn't a procedure for that. So that really requires a partnership with healthcare providers who want to see you regain your resilience, your vitality. We're looking to coach up those opportunities that restore someone's health, their capacity for healing, their energy level. And that requires a great deal of accountability. So we're not just merely in the role as healthcare providers, brokering prescriptions to everyone. This is a collaborative situation. People need to be engaged in their own health. This is a healthcare stewardship proposition. We're here to help, guide, and coach, to collaborate. And then there is a level of accountability that's expected as well. Where can we use labs then, not just to monitor how well a particular intervention is coming along, but how well are you managing your health? Are you aware of these numbers, what they mean, how they serve as guideposts, and opportunities then for further improvement? It's a story. This is, we'd like to see people avoid events like I experienced. On the other hand, most of us get to a point in our lives, in our careers, where we're stuck. We really don't realize the danger we're in. There's a great deal of self-denial, and we're on a hamster wheel. We're stuck. And sometimes it takes some real honesty from a healthcare provider to come alongside you and say, with a healthy dose of some truth, and identify opportunities for change.
So you talked a little bit about fatty liver, and you said your doc said, watch your fat intake. Any comments about that?
Well, I had to educate myself on this. Unfortunately, back in the late 70s and through the 80s, everybody remembers the old food pyramid and some of the nutritional advice that we all followed, where fat is bad. And unfortunately, we didn't identify which fats are bad and which ones, and what causes fatty liver. If anyone has ever eaten foie gras, we don't get fatty goose liver by feeding them saturated fat. You get fatty goose liver from an overabundance of sugars and starches. So it's actually a carbohydrate metabolism problem.
To make foie gras, they actually force feed corn.
Force feed, yeah. So it's carbohydrates and sugars and starches that make that fatty liver. So if we know that from the culinary world, why isn't that knowledge applied in the medical world? So that requires rebalancing your dietary intake. Yes, weight reduction is powerful, but not because it somehow reduces the fat in the liver. It's because it has a major influence on insulin production and insulin resistance. And then individuals who've got fatty liver typically are deficient of certain antioxidants, vitamin E being one of them, and then other building blocks that are essential for liver maintenance, like glutathione. So I didn't know those things. And so there are strategies, there are ways that we can go after correcting these issues. And among them, the very first thing is to stop the intake of things like ultra-processed foods that have high fructose corn syrup, refined sugars and carbohydrates, and then the really damaging or oxidizing fats, the vegetable oils, the highly processed fats, the trans fats. Those are very, very damaging. And we really don't have appropriate metabolic machinery as humans to process those substances. But unfortunately, they come in foods that often are labeled as though they're heart healthy.
Yep. They know the keywords to use, and unfortunately, you gotta be one step ahead of the of big food as they mess with their food labels. Have you got a few minutes for me to go through a couple of slides that talks a little bit more about fatty liver?
Of course, let's go for it.
So you're right. Your doctors didn't know that much about it. You had to learn about it. I've had to learn about it over the past few years as well. And in fact, none of us are alone. There's been a whole learning curve for the medical community. When you said fatty liver in the past, that used to mean alcohol. So let's talk about, but that's not so much the case anymore. It's normal for the, if you would, Gilbert, if you'll share my screen. It's my slides. It's normal for the liver to contain fat. However, if it's more than 5 to 10% of the liver's weight in fat, then it's called fatty liver, or steatosis, meaning fatty. Fat deposit is usually common among alcoholics. That's the reason I made the comment I made before. That's why we used to think of alcohol. But there's a type of fatty liver disease that's not caused by alcohol. It's taking over in terms of being the most common cause of fatty liver. It's called NAFLD, or non-alcoholic fatty liver disease. NAFLD affects up to 25% of adults. Some folks would say 30% of adults, or 1 in 3, and around 5%, or 1 in 20 children, maybe up to 1 in 10 children. When the fat builds up, it causes inflammation and damage. That's called NASH, non-alcoholic steatohepatitis. So the H in there is the key. Hepatitis meaning hepa meaning liver, and itis meaning inflammation. NASH is the more severe form of NAFLD. NASH can lead to scarring of the liver, cirrhosis, and even later on, cancer, liver cancer. So, and there have been some developments in terms of number one causes of cancer. I think isn't it now the number one cause of liver cancer among men? Among one of the genders, it's taken over as the number one cause. Non-alcoholic fatty liver disease tends to develop in people who are overweight or obese, or have prediabetes, insulin resistance, high cholesterol, or high triglycerides, all of which are in that same constellation of metabolic syndrome. Rapid weight loss and poor eating habits may also lead to NAFLD, and we're not going to go too deep into that right now. However, some people develop non-alcoholic fatty liver disease even if they do not have any risk factors. There appears to be something genetic about their metabolism. Symptoms, just like with insulin resistance, there are no symptoms in the vast majority of cases. So we have to have an index of suspicion. We have to be thinking about it. For patients who do experience symptoms, there may be some amount of abdominal pain, fatigue, tiredness. In addition, the liver may be enlarged in some children. Some patients experience dark discoloration of the skin or the neck or the underarm region, similar to what you see with some cases of prediabetes and diabetes. Now, more than 6 diabetics and 9 severe obese people out of 10 have non-alcoholic fatty liver disease. So as you see, very, very significant risk factors with obesity and prediabetes, diabetes. Now, how is non-alcoholic fatty liver disease diagnosed? Initially suspected if blood tests show high levels of the liver enzymes, AST and ALT. Those of you who have been my patients, you know that we routinely screen for that. Often an ultrasound is used to confirm the diagnosis. In an article published in the American Journal of, that's röntgenology, that just means X-ray. In a journal article last month, researchers found a new potential way to diagnose patients with high-risk non-alcoholic fatty liver disease through fibrosis and multiple CT findings. However, the presence of NASH remains elusive on CT. We'll talk about ultrasound a little bit later. It's one of the key current ways of diagnosing it. How is it treated? Well, you treat it the same way you do obesity and insulin resistance. Lifestyle is king. To prevent NAFLD, talk to your doctor about ways to improve your liver health, lose weight, start looking at how many carbs you're eating, and start looking at your overall body fat composition. Lower your cholesterol and triglycerides, avoid alcohol and unnecessary medications, and obviously control diabetes. So, Gilbert, you want to show us this movie from Nature magazine?
The liver is the body's metabolic HQ, detoxifying the blood, making proteins and hormones, aiding digestion. The liver is the body's metabolic HQ, detoxifying the blood, making proteins and hormones, aiding digestion and processing nutrients. Most people know it best as the organ that clears up after a night in the pub, and that heavy drinking can cause severe damage. But it's actually non-alcoholic fatty liver disease, or NAFLD, that now has doctors and scientists worried. Linked to the global increase in obesity, 1 in 4 people has a fatty liver. When calories are well matched to the body's energy consumption, the liver orchestrates an ebb and flow of energy storage and distribution. But when fat and carbohydrate flood the liver, the system becomes overwhelmed and stops working properly. If more than 5% of cells in a person's liver contain large fat droplets, that person is said to have a non-alcoholic fatty liver. At this stage, a fatty liver is still reversible with changes to diet and exercise. But without intervention, things can get much worse, leading to cell death and chronic inflammation. If this happens, NAFLD becomes a condition called NASH. Unchecked, it increases the risk of cardiovascular disease and serious liver problems, including cancer and cirrhosis, which is when scar tissue forms in the liver. Treating NASH is crucial, but even at advanced stages, its symptoms can be vague, and doctors struggle to diagnose it. Currently, we need a slice of your liver, hold the fava beans and Chianti, to spot fat depositions, inflammation, and scar tissue. But there has to be an easier way. Scientists are developing an accurate blood test. Or we can look to the coolest guy in the hospital. New, more sensitive ways of detecting how ultrasound waves change provides a picture of how much fat and scar tissue is in a liver. Numerous studies have shown that diet and exercise can reverse fatty liver and even NASH, but lifestyle change can be the trickiest prescription of all. And if NASH continues to worsen, doctors will want to intervene. Currently, there are no drugs specifically approved for treating NASH. However, hundreds of drug trials are underway. Some drugs act in the gut, halting fat absorption and stopping the release of pro-inflammatory signals. Most target the liver directly, aiming to stop the metabolic stress that triggers NAFLD. Others try to prevent NASH by blocking the effects of metabolic stress, by stopping inflammation and cell death, and some drugs are making progress on that difficult scar tissue. Livers work relentlessly to keep us going, and researchers are working ceaselessly too to better understand, diagnose, and treat this increasingly common condition, helping us all live a healthier life.
When we were reviewing the videos before the show, Kevin, you made the comment that even the Nature magazine, as good as science as they have, their preliminary focus was on drugs. And again, it's like everything else. In medicine, we go first with the drugs, and that's usually not the right direction. Any other comments before we Cap or other comments before we get into Q&A?
I just sincerely appreciate the opportunity to come on and speak of my own experience and to participate in your educational efforts in regards to insulin resistance is one of these root causes of cardiovascular disease, and fatty liver as one of its partners in crime.
Exactly. Fatty liver is a big deal, and it's like insulin resistance. It's just under-recognized. So just another tech issue or disclaimer. We went through the whole process of getting me a new computer, getting it up, getting it rolling, testing it a few times. And for some reason, my video component continues to freeze. So that's why we have that picture of me up there rather than just a frozen image. Hopefully we will figure this out at some point. I think it may have a little bit to do with our local networks, an internet service provider. We don't have the greatest, but we do. It does look like or sound like the audio gets through. Bambi Gage, good morning. Wanted to let you know how much I look forward to these weekly talks. Let you know you're appreciated. You guys are appreciated as well, Bambi. If you weren't responding, we wouldn't be doing it. Good morning, Dave Murphy. Dave shared with us, by the way, I think he's at this point beyond 150 pounds of weight loss. You mentioned, and I can tell from looking at your face, Kevin, how much have you lost from peak weight?
I think I dropped about 30 pounds, which brought me down to a BMI of about 23.
That is a much healthier place to be.
Yes. And one of the significant tools, in fact, I'm using one now. Yeah, that is a CGM. But periodically I will use one of those and monitor my own metabolic progress. And especially right now, while we're all kind of snowed in here in the beautiful Commonwealth of Kentucky.
If I remember your case, your insulin resistance was not really that striking. Am I right? It was fairly subtle, wasn't it?
We found it. It was there. We did use a Kraft insulin survey. There were a number of metabolic markers that were present, again, in retrospect, that pointed to insulin resistance. I also had low vitamin D. But once and you were the one that put me onto it, but using a CGM, in my first experience with that a couple of years ago, it was remarkable which foods would really set it off.
Tell us about that.
Well, it's not only which foods, but sometimes in what combination. And so I know in my own metabolism, I do very well on healthy fats and proteins and selected carbohydrates. It depends what they are. Refined carbohydrates and starches, I will observe, I'll observe some significant peaks after a meal. Now, in my own situation, it doesn't take me very long. Within 30 minutes to an hour, I've not only made the correction, but on some occasions, then I will overcorrect and go too low. I'll experience a reactive hypoglycemia. That's an experience common to a lot of people. And that fits in the spectrum of insulin resistance.
It does. You know, I've seen that pendulum swing back and forth twice now. That reactive hypoglycemia was considered a thing clinically back 30 years ago. Then 10 to 20 years ago, everybody was skeptical of it. No, that doesn't really happen. Once you actually get deeper in terms of understanding the clinical progression of the disease, you see the same thing with thyroid. The pancreas and the thyroid both. When you first start getting into problems with it, you tend to have more of an overreactive endocrine response than underreactive. Any comments before we move on? That was very helpful, by the way. Any comments before we move on?
The other accompanying factors, tremendous amount of inflammation and loss of antioxidant capacity. And it's these factors, the hormonal dysregulation, such as insulin resistance, leptin resistance that you've spoken of here before, thyroid disorders, testosterone deficiency, those all fit in this larger picture of insulin resistance. The oxidative stress issues that damage organs in the body, the inflammatory response, sources of inflammation that often are hidden, but they're periodontal disease, so poor oral health, or sources of inflammation that are coming from somewhere in the digestive system. And finally, the genetic factors That was another component that we uncovered as I was working with you to identify two very significant genes that placed me at unusual risk for early cardiovascular disease. And those are actionable. A lot of people think that just because a gene is present, that means you can't do anything about it. Well, not all genes are like the ones that govern the color of our eyes or our hair. There are a lot of genes that express themselves a bit like putting your foot on the gas pedal or on the brake. Diet, environment, other influences influence the way those genes express themselves. So your genes aren't necessarily your destiny, but it sure helps to know if some problem genes are present.
It really does. So while we're talking about you and the CGM, Bob Bell had asked how you measure or monitor your IR. As you mentioned, we did a OGTT, then you did a full-blown Kraft insulin survey, saw some subtle things on there, and then you did the CGM, continuous glucose monitoring.
Correct. Yeah. Yeah.
He's asking, have you used HOMA IR?
I do.
Go ahead.
Yeah. Thanks, Bob, for the question. There are a number of, I guess we could call them biomarkers, lab results that are helpful. The HOMA IR being one of them. Hemoglobin A1C certainly can help. There are other markers that I look at, and then one of the other indicators of insulin resistance is how much correction occurs on some of the inflammatory markers that may be indirect. And then the other issue is using a lipid NMR, so particle size and particle count. My case, I was in the hospital experiencing a heart attack with an LDL cholesterol level of 88. Well, it wasn't until we did a lipid NMR and discovered I had a high particle count of small dense particles. That's the issue, not the LDL-C number. So that's also a helpful measure of insulin resistance.
Really good point. You know, I've heard several people say, and I agree, that you really don't want just a simple cholesterol panel. I can actually, you know, you and I both know, we can actually tell some stuff from that. You can tell if somebody, sometimes you can tell if they have FH, familial hypercholesterolemia. And you look at the triglyceride over HDL ratio, that tells you a lot about the ratio. Glucose.
Very important.
But what you're talking about, you're not going to see on a standard cholesterol panel. You need to get fractionation. And yes, we do that on all of our folks. I don't use HOMA IR that much. The reason is the HOMA IR calculations I've seen have all been static. And as you know, you can get great numbers when somebody's fasting. It's when you challenge it that you really see the rest of the story. We've got a fellow named Janice Jansons who has made several comments. One of them is he thinks eating fat is going to cause a problem with testosterone. My view, Janice, is that one of the most common problems associated with low testosterone has been body fat. But testosterone is actually absorbed by body fat. So obesity and increased BMI are, to me, that and age are the two most common reasons that you tend to see low T. Just like they're two of the major risk factors for insulin resistance as well. And I can tell you, you know, people just continue to get into this issue about vegan versus other types of diet, vegan versus low carb. You can go low carb on vegan. You can actually even go keto on vegan. Mm-hmm. The question is, where are you getting your calories? And Erland FR. Erlen, where is that comment? I think Erlen made a couple of comments about, he goes on, he wants to know what the guidelines are for low carb. He's saying 20 grams total carbs, 20 grams net carbs, or carbs less than 4%. That tends more towards keto for most folks. Now, I have a lot of folks who are just comfortable long-term on keto. I tend to be a little bit kinder, gentler, and allow a little bit more vacations because here's the thing. You may have heard the old saying, look, this is not a marathon, it's a sprint. Let me just make a couple of comments about that specific analogy versus this. World-class marathon is 2 hours. You know, I've seen my level of marathon's about 4.5 hours, and then 5 when my slower states. We're not talking about hours here. We're not talking about days. We're not talking about weeks, months, or even years. We're talking about decades. So if you can stay on keto for decades, then good, do it. Most people tend to be a little bit better off and a little bit more comfortable with more of a low carb diet. I just try to get people to focus on at least 100 grams of total carbs per day or less. Kevin, what are your guidelines?
I think going as low as 20 grams, that's perhaps a bit low. I think people may do better on that. We have to appreciate that some people have different, their metabolism varies.
Exactly.
So that is actually a better question. I would actually defer to Angela on that one. And that's the expertise that she brings to our operation here in Second Chance Health. But we recognize that not everybody has the capacity to become so well fat adapted. So it's a matter of what you eat, the composition of what you eat, and when you eat it. So that the whole concept of feeding window or intermittent fasting may work well for some people. And then we also need to take into account certain genetic variations, and especially if someone carries the ApoE4 gene, they need to be very careful with fat consumption.
That is a long-term big issue. I have to tell you, I think it becomes very confusing. As I've done more work in terms of that space, I've gotten a little bit more forgiving of having fat in the diet, even if you have ApoE4. With a major focus on keeping that BMI down and the body fat down. Mm-hmm. So if you're, however you can get there, tends to be a major focus for my folks. So Erlen, we need more docs like both of you, like Doc Martin at the BBC. You're telling your patients the hard truth. I think he's talking about that show. My wife and I watched that.
I hope I'm not as blunt as Doc Martin, although I sure appreciate his small town practice.
I appreciate
Port Welland, yeah.
My wife Janice, who many have seen on the channel, and you've met, she accuses me of having about the same level of communication skills. You know, she's had to live with me for over 30 years. Your message is critical. The best thing you can do is be blunt. How else can we save lives? So thank you so much, Erland. Haley's sharing. She knows she or he, I'm not sure, very much aware of their insulin resistance. Simone DeSample, Dr. Berg shares these findings. I get a lot of people that confuse me and Eric Berg. And I don't know if that's a good or a bad thing, but he and I do share a lot of the stuff that he talks about, especially in terms of insulin resistance and getting the carbs out of that diet. Not quite as strong on some of the supplements that he talks about. Eric's SMR, excellent information for clinical dietitians. Thank you very much. I said Eric, I meant Vicky. Warhawk, good morning, Dr. Brewer. If I choose to become your patient with heart issues, do you offer a full diet eating plan included in addition to your medical services? Well, what we do, Warhawk, there's similarities between our services and Dr. McChord's with Second Chance Health. You have basically with both of them, you get a focus originally with understanding the fire inside, as Dr. McChord talked about it. And then next, looking for what's causing that fire inside. And for about 80% of us, it's some version of insulin resistance. And then so we start focusing on helping you deal with that. The biggest, most effective ways of dealing with that, yep, prescriptions can help. Yep, supplements can help sometimes, but lifestyle is the issue. You cannot outrun a lifestyle issue. We both have spouses that are very deep into the medical space. My wife, Janice, has about 6 years of training. You got 2 doctorates, one at Hopkins, one at Vanderbilt, in terms of just general health coaching. She put that on top of a physical therapy degree. Angie with Second Health, Dr. McChord's wife, has a program that's a little bit deeper and much more focused on diet in and of itself, functional diet. Do you want to talk a little bit more about that, Kevin?
So Angela brings a whole set of skills to our operation here through training called functional diagnostic nutrition. Now, where she is not in the business to diagnose a medical disorder, she has access, and together we have access to a number of functional labs that provide us an overview of how someone is doing nutritionally and metabolically. So we can analyze, there's various components that we can analyze, but out of the urine, or a comprehensive diagnostic stool analysis. So these are ways that we can get at understanding and unraveling the chaos occurring inside. And then Angela takes this into an organized approach of manageable lifestyle changes. What are your top 3 concerns? Where can we do less of something, more of something, and move this needle in the direction of improved health and well-being? That's not something that conventional medical care does very well. We're always focused on the disease, on the pathology. And it's really interesting when you just ask people, when was the last time you felt good? I mean, really good. And even if someone hasn't been labeled with a medical disorder, you don't just default to healthy. And it really makes people think, and they got to dig back to think, well, the last time I felt good, I was in grad school, or it was before my first child was born. So we help to unravel that story, that personal story, and the factors that are creating a drain on energy and health. And so we can use the diet, we can use targeted supplementation to help recharge and rejuvenate, to help people age in a more healthy way.
So Vagabond Sojourner and Haley Wright have some good topical questions. If a patient doesn't want to take statins, what would you recommend that they take to help lower inflammation, and how would that patient best measure if indeed his or her inflammation has been lowered? So again, when you go back and you think about the most common driver for inflammation is insulin resistance, then you start looking at measures of insulin resistance. And Kevin covered those in his own experience, looking at an OGTT, oral glucose tolerance test, an insulin survey, using a CGM, continuous glucose monitor, Freestyle Libre. Those are all ways to measure what's going on in terms of the most common drivers of inflammation. There's a thing that we call cardiovascular inflammation panel. We look at microalbumin creatinine ratio, LP, PLA2, called plaque 2. We also look at myeloperoxidase. These are all things that actually, plaque 2 and myeloperoxidase are actually enzymes that are released by our own immune cells when it's trying to attack and dissolve plaque in our artery walls. C-reactive protein is the most commonly assessed biomarker of inflammation, but those are the ones that we look at. There are others that are available, like IL-6 and some of the others. But again, you get a pretty good picture with these. Mm-hmm. And what do you take? Like we said, lifestyle is king. There's a whole lot to do with lifestyle. Now, there are supplements that help. There are medications that help. For example, vitamin D3 has a significant association with not only prevention of COVID-related problems, but perhaps because of that, or because of the next thing, maybe that's why it helps with COVID. It does have a lot of evidence indicating it decreases insulin resistance. So it's a very important supplement. There are others as well, cinnamon, K2, some things like that. Metformin, which...
Yeah, and metformin, yes.
Haley Wright actually asks about metformin next. What's your opinion on metformin for treating IR? I recommend it. I use it personally. There's a study called TAME, Targeting Aging with Metformin, and it was developed not by Dr. Oh gosh, I'm blanking on his name. I had it right at the tip of my tongue. He's at Albert Einstein in New York. He's the principal investigator for the study, but the study was really developed by the gerontologists at the National Institute of Aging. And basically what they were saying is, we know that the majority of what we call normal aging is really associated with insulin resistance, which happens as we age. What if we just put metformin in the water? And that's essentially the study hypothesis for the TAME study. Once you get age 65, half of folks get a placebo, the other half get metformin. Other folks like David Sinclair, world-renowned anti-aging researcher at Harvard, have taken it as early as in their 50s, early 50s, just as a preventative for aging. Again, I think it has several different impacts, which may be beyond the scope of the discussion for today. People ask me, well, how does metformin work? Well, the standard answer is it decreases the liver's ability for what we call glycogenesis. Glyco meaning sugar, genesis meaning making new. The liver stores glycogen, which is basically just chains of one sugar molecule after another. When we hit, when our brain tells us to hit cortisol in the morning for dawn effect, or epinephrine for the fight and flight, they stimulate that liver to release the molecules of glucose off of that glycogen and raise our blood sugar. I personally think there's more than that going on. For example, about 20% of us will have GI symptoms, gas, some even nausea, maybe some diarrhea for a week or two when we start metformin. If you look at somebody's gut that has insulin resistance, it's got a different biome from someone who doesn't. And sure enough, if you look at someone who's been on metformin, it tends to drive it more towards the non-insulin resistant type biome. So I said maybe it wasn't the scope of this project, but I went ahead and talked about that anyway. We don't fully understand all the mechanisms for metformin, but those are just a couple of them. James's Aunt Martha Reich, good morning. Please speak about nocturnal hypoglycemia in relationship to insulin resistance. Now, I'm not familiar with a specific clinical entity called nocturnal hypoglycemia. I am very much familiar with the fact that, like blood pressure, most of us tend to have our lowest glucose during the night. Before I talk about that, Kevin, any comments?
Brief thought on this. Remember, we're looking at the interplay of multiple factors, and that includes the daily pattern of cortisol and one of its companions, and that's DHEA. So those hormones run through a cycle every day. There's a diurnal pattern. And the balance, the relative abundance or deficiency of those two hormones also determine whether we are in a catabolic or anabolic state. So I'm sure that it has some influence on nocturnal hypoglycemia.
So again, just to translate the doctor speak, the catabolic state, you may have heard it in our channel. We've done several videos on autophagy, auto meaning self and phage meaning eating. So one of the big positive metabolic improvements that you see with autophagy, or that catabolic state, is that that's basically our body's mechanism, our cell's mechanism for taking out the trash, for burning the recyclable materials. If we're never at a state of low calorie or calorie deficiency, our cells never get to that catabolic state. It's been shown to decrease inflammation, especially cardiovascular inflammation, many times. So Martha, for those of us who have good glucose control, I do expect many of us, especially at night, especially between the hours of midnight and 5 a.m., to reach our lowest point in glucose, similar to the cycle that Kevin was talking about. Go ahead.
Oh, Dr. Ford, one other thing that I've got in one other comment here, certainly using a CGM, just an awareness of the limitations of the technology. It's an excellent tool in the toolkit, but if someone is repeatedly observing readings below 70 or what would be in a hypoglycemic range, cross-check it with a glucometer.
Yep.
And then always ask, before you look at any kind of medical device, look at the patient first. Is someone truly symptomatic, like they have hypoglycemia? Because sometimes the CGM can yield a false low reading as well. So always cross-check it.
So I just noticed, we're just going on and on here. It's 12:06. I have some other meetings. I know that you do as well. So I think we're getting the show's getting a little bit long in the tooth. Recently, we've been getting so many really good comments. We haven't been able to cover them all. And I apologize if you've made a comment. We haven't been able to cover it. We do try to get to comments that are left on the video once it's published. Any comments before we sign off, Kevin?
It's been a pleasure and an honor. Thanks to you and to the entire PrevMed audience.
Thank you so much. Gilbert, could you hang on and let's see if we can do something else with this technology on the way after we close out? I thought you did great. You have any comments, questions, concerns?
Just thanks for having me on. I appreciate it. This is the first time I've ever done anything like this. So there's always a first go.
That's right. And I think you did great for your first.